you don't need any lectures from anyone. But my purpose of this talk is to just give us a quick overview, see how we can and when to think about these things, and what kind of structure we can follow if we ever think that we are having a patient with pulmonary embolism in our practice. I do understand that all of us might not have the same situation or working facilities. So just I do apologize if you feel that I'm talking about some things that might not be easily available in your practice. Since last time I worked in Pakistan was about what 11, 12 years ago. So it's been a long time, obviously, but I try to make it as simple as possible and try to think about the situations in which from tertiary care to even secondary care people who encounter such a patient can deal with it. So I'll start off with my talk. Before I start off, I just want to let you know I'll be doing some quick online quizzes. And so if you can go to slido.com. I've just shown you the website address and use the code 84224 and you on your mobile phones or laptop, whatever you're using, and then we can participate in these little short MCQs or quizzes together. The objective of this study is when to think about pulmonary embolism. Obviously, we see day-to-day patients. Everyone is coming with chest pain, shortness of breath, cough, fever, especially with the coronavirus situation going on. So it's very common to have these kind of presentation, but when to actually think that it might be pulmonary embolism in that long list of differential diagnosis is the trick, basically. So what I want you to take from this talk is that when do you actually think about PE as one of the potential differential diagnoses, and when not to think about pulmonary embolism in terms that if you think that this might be PE or not PE, when to actually go for the long workup, which is potentially costly for the patient as well, potentially resource heavy workup that we have for pulmonary embolism. So it has to be due to have some special considerations for that as well. In terms of diagnosis, once we have diagnosed it, what to do next, how to manage it, and also I have a very brief talks about a few special situations in which PE can present and how to deal in that situation. So before we start off, I have a short question on Slido, and it's nothing complicated, so don't think of it as some sort of exam. So let's see how we can go about it. Um, Let me see if I can share the screen with you. And this is the question. Are you guys able to see, I hope? So you are seeing a 48-year-old male smoker with complaints of acute shortness of breath and chest pain. Initial observations are saturations of 93%, blood pressure of 110 by 62, pulse of 117 per minute, temperature, mild temperature of 99 degree Fahrenheit. What would be your most likely diagnosis? You can select uh, any of the correct answer. It can be more than one.
Sorry, Mohsin, if you can click the present on the top, the green button present just beside the share, and that will show it in a full screen. Yeah.
Okay, there you go. So I hope everyone is able to see this slide now.
Yep.
Yes, okay. Going with the name of the talk. Um, is there any other responses yet? I don't know if people have joined enough, but the correct answer, if I want me to tell you the correct answer, would be uh, all of them. So this is just want to emphasize the fact that PE can be presenting among all the very vague complaints that we get all the time in our clinics or emergency departments or even admitted to our wards. So anyone can come with acute shortness of breath and chest pain. It can be simple uh, acute coronary syndrome. It can be a PE. It can be a pneumonia or a pneumothorax, or even a simple costochondritis or gastroesophageal reflux. So that's the tricky part, how when to think that it can be a PE among all the presentations that we are going to talk about. I'm just going to go back to my slides now. Uh, so just a bit about the boring parts of the presentation that I'm going to go not going to go in detail. So incidence is about 60 to 70 per 100,000 patients. It's in the UK, basically, I'm telling you the data. So it's not as common, but not very uncommon either. So it's something of a considerable number. The interesting part is the largest numbers of the PE happen while the patients are admitted in the hospital. So that tells you that it's related to sick patients who are hospitalized in the bed all the time. They are prone to get PE. And about 25,000 deaths every year from hospital-acquired venous thromboembolism. So that gives you an idea of its significance in terms of death burden. And it's the second most common cause of sudden death, non-traumatic death in the outpatient as well. So it's a quite a lethal thing actually, easy to miss, but can be have disastrous consequences. And the incidence of this condition increases with age. So it's normally not a disease of the very young. Just about pathophysiology, just wanted to know, just going back to your medical school, think about Virchow's triad. I'm not sure if all of you remember that or not. The reason I want to talk about Virchow's triad is because if you ever think about your patient coming with acute dyspnea or chest pain, just think about if, do they have any of the risk factors for the Virchow's triad? Basically, anything that is causing venostasis, which can be mobility, paralysis, plaster cast, heart failure, or any vessel wall inflammation such as trauma, major surgeries, any catheters in there that are a source of making a thrombus, or their hypercoagulable states such as patient on estrogens, pregnant patients having any tumors or cancers that are on anti treatment for malignancies, or acquired or inherited procoagulant status like protein CNS deficiencies and antithrombin deficiencies. So if you ever think about your patient have any of these factors that can or are a part of the virtuous triad, that gives us a hint that yes, we have to think about PE. And the basic part is due to just immobility or whatever cause, uh, the blood flow slowed down in the lower limb, clot forms, breaks down from the lower limb, travels all the way up to the right side of the heart, and then goes into the pulmonary circulation and gets blocked there and blocks the supply to the lungs. Um, the lungs are natural filters basically. So God has made us, and all of us have small tiny micro emboli always passing through, and we don't even have any problem because this is how God has made our pulmonary circulation, that it just filters small emboli without any trouble. It's only when if we have a very large clot that actually goes there and blocks some main vessel that we have a pulmonary embolism. uh, so if you ever have a PE, most likely it's from the lower limb. Having said that, sometimes upper limb sources are there as well due to malignancy or any other causes. And once you have blockage of the blood vessels, this leads to a dead space kind of situation in which there is ventilation, but there's no perfusion, and that leads to difficulty in breathing and oxygenation. Risk factor wise, most of it, as I said, is the increasing age, obesity, pregnancy, cancers, all through the list that you can see. And if you can think about the virtual triad here, all of them, these factors fit in one way or another in that triangle. So something to think about, someone who's on smoking, stroke, on estrogens, there are in somehow procoagulant and lead to thrombi and leading to pulmonary embolisms. Clinical feature wise, 70% of them present with acute shortness of breath or dyspnea. And the differentiating part from other causes of dyspnea, which can be quite a lot, is they are not explained by your examination findings, ECG finding, or chest X-ray. So a person who's coming very breathless, you examine him, is short of breath, is obviously in respiratory distress sometimes, and but their chest is clear. You don't hear any wheezes, crackles, or any other findings. Uh, there's no signs of pneumothorax or anything like that. ECG is not showing anything clear cut. ST segment changes in terms of myocardial infarction or any other cause, and their chest X-ray is essentially normal as well. And this is the kind of patient that you should always think about, that yes, maybe I'm dealing with pulmonary embolism. Apart from that, you can also have pleuritic chest pain. So they can also have, when we have a advanced embolism in which it has led to death of the lung tissue and it's caused infarction. So it can lead to pleuritic kind of chest pain. So it is localized chest pain. They can localize the pain where exactly it is. It's very sharp kind of pain that they have. And they sometimes can have shoulder pain or epigastric pain as well, which are usually either referred or from the ischemia of the right ventricle due to advanced pulmonary embolisms. Apart from that, hemoptysis is one of the major risk factors. So any patient who's coming with hemoptysis in Pakistan, I know our first differential should be either TB, or it can be TB or malignancy, but also think about PE, especially in not a very old person who's relatively young or had any other risk factors as described before. And they can also present with syncopal episodes or seizures due to cerebral hypoxia. And finally, your patient can present with cardiac arrest, and PE should be one of the differentials. And presentation wise, normally when they present, it can be either a very massive PE in which they have a cardiovascular compromise manifested as a systolic blood pressure less than 90, or in a cardiac arrest or peri-arrest situation. Or it can be a submassive PV in which the patient is stable enough to maintain a good blood pressure, but they have evidence of myocardial strain or right ventricular strain. It can be evident if you check their cardiac biomarkers, so troponin or proBNP can be significantly raised. Or the other option may be if you are able to do a bedside ultrasound, which I'm not sure is available everywhere in Pakistan in emergency departments. It's very common in the rest of the world and now in emergency departments. So if you have a dilated right ventricle on the RV, or there are certain other signs that are there for on the bedside ultrasound as well. Or if you do a CTPA, it can also show you a right ventricular strain or dilatation. So these in that situation, it's called a submassive PE. The reason I'm telling you about massive and submassive is that their treatment differs slightly in terms of how we treat them. They can also present a simple pulmonary infarction in which there is no strain on their heart at the moment. There are no raised cardiac markers. They're able to maintain a good blood pressure. And this is the difficult population that we are talking about, because they are stable enough, they are talking to you, they look comfortable, they're just coming with just mild chest pain or just light breathlessness on exertion maybe. And that's the population that can be easily missed. So just think about PE in that situation as well. Or it can be a subacute PE, that pulmonary embolism is an ongoing process, been happening and it's been missed, and it's just kind of a chronic kind of a subacute presentation can happen as well. Physical examination wise, when we do examination, the hallmark of PE is that essentially a patient, there might not be many lung findings or chest finding on examination. So a patient that looks tachypneic, that looks tachycardic, but has an unexplained low oxygen saturation. So you have low saturation, but you don't have any other obvious cause for it. The chest is normal for examination. There are no signs of pneumonia or pulmonary edema or a pneumothorax for that matter. But they obviously look in respiratory distress or having signs of tachypnea or tachycardia. You have to think about PE. They might have signs of hemodynamic compromise, and that by itself indicates that it can be a large clot somewhere lodged into the pulmonary circulation. And it probably is a sick patient and is a high risk of death at that time. On examination, you can have other risk factors evident on examination. So, for example, you can see a vascular catheter or a plaster of Paris cast, any evidence of major recent surgery that might indicate that the patient might be at risk for having a PE. Diagnosis wise, when we come to the diagnosis, this is the tricky part, because when we come to PE, it's very easy to think about PE, that every patient might have PE. But when should we think about investigating them further? Does every patient need to be worked up? That is the tricky bit that we need to think about. So when you do this initial workup, so if you do, their oxygen saturations might be low. If you do an arterial blood gas, you might have a low PaO2, because of their tachypnea. They're breathing so fast, they're washing out all their carbon dioxide, so they might have a decreased PaCO2 as well, and their AA gradient will be low as well. If you do a normal blood work, you can do it. That is, it normally should be on a normal. There are no raised inflammatory markers, because that will help us rule out chest infection. In terms of cardiac markers, it might be raised in a submassive or a massive PE. So it can be a red herring, because if you think about someone with chest pain with raised markers, you might think about unstable angina or NSTEMI. So it is also something to consider, that it can be a PE with a big thrombus burden. Um, if you do a chest X-ray, most of the times it will be normal. The typical findings of PE are rare, and they are not very common. So that's why you have to think about in the books we always read about Hampton's hump and Westermarck sign and all that. They are mostly very rare, and most of the time they are retrospective. So you do a CTPA, you found a PE, and once you uh, uh, when you do the CTPA, you find this PE, and then you look back into the chest X-ray and you're like, oh, I can see some Hampton's hump. I've only seen once in my life, and that was also a retrospective thought. So it's very non-clear things that we think about chest X-ray. Essentially, a normal chest X-ray with respiratory distress, think about PE. ECG changes also, when we think about it, we are always told about S1Q3 3D, but this is not a neither specific non-sensitive for PE. They are found sometimes, and they can indicate PE, but in the absence of S1Q3, which is basically an S wave in lead 1, and Q wave and a T wave inversion in lead 3. These are normally advanced changes, and not commonly found in the early PE presentations. So an absence of S1Q3E basically doesn't rule it out. Um, Most of them it present with either a sinus tachycardia. The other changes with the right ventricular strain that can happen with pulmonary embolism can be there as well, such as right bundle branch block, or a right axis deviation, or non-specific T wave changes, either a tall T wave or inverted T wave in anterior chest leads can also happen. But the most common ECG finding in a PE is a simple sinus tachycardia, because the patient is tachycardic at that time. And these are just a couple of pictures about what we are told about chest X-rays. So normal X-ray normally is found, but as I said, on the picture on the left, you can see a area of decreased vascular findings on the right side of the lung, and the white arrowheads indicate this is called the Westermarck sign. And on the right picture, you can see a big, large pulmonary infarct, as a triangular in shape, and that's called the Hampton's hump. Very hard to actually call that out on a normal patient, and they're not mostly, as I said, retrospective mm, findings. So now I come to the main part of the talk, how to go about it, how to have a diagnostic approach for a patient that we think might be having a PE. And there's a role of what we call the physician's gestalt, which basically means that what is when we think about the patient, the examination findings, our initial blood work, and ECG and chest X-ray, and they are more or less fine. Then what do you when do we think that okay, this patient, shall we go think of them as a potential pulmonary embolism, and when can we go for their workup? So this is where our own physician gestalt comes in work. So it's basically our own gut instinct that what how much risk we think that this patient might be, considering the risk factors and the examination findings, that it might be having a PE. Normally in literature, they said you should be having a 5 years experience post graduation to be able to have a good physician gestalt to have a good estimation that this patient might be having a PE, comparable to using any risk stratification courses. Um, so what we do normally, to instead of using our subjective findings, such as having our own gut feeling that okay, this patient might be having, this patient might not be having, this is very subjective. So to counter that, they have come across certain decision making tools or risk stratification tools. The most common among them is the Wells criteria. I think most of you must be well aware of it. I don't want you to learn any of them by heart. Nowadays everyone has a smartphone, and you can have those apps and always look it up whenever you think about it. So it's not about learning the each and every aspect of these risk certification scores. Instead, what I want you to remember is to just think of it, what score to use and when to use. So most of the time we use the well score to risk classify our population into low risk, medium risk, or high risk. So I'll tell you the Wells criteria. Uh, so this is, if you look into this Wells criteria, you will see that um, the highest score, which is 3, is still your own physician gestalt, which is clinically suspected DVT or PE. So this is something that you have to think about, that if you think that the PE is the most likely cause, it's still scoring a big number 3 on the Wells criteria. So it's a combination of your own estimation as well as other objective measures. And according to what score the patient gets, you can divide them into low, moderate, or high risk. I'll tell you in a while about how to go about once you have this division about which patient fall in the low risk scoring of less than 2, or someone who's scoring between 2 to 6, what to do, and or people who are scoring more than 6, what to do in that situation. Uh, in terms of mortality risk or occurrence risk, a patient with the score of less than 2 is having less than 15% chance of pulmonary embolism. Moderate risk will have 15 to 40% chance, and a high risk is having PE risk of more than 40%. So these are significant numbers, and that's why I'll tell you what to do when we have a moderate or a high risk of PE. And we'll also use a thing number called a pulmonary embolism rule out criteria. So this is only when we have a low risk score, less than 2 score of Wells. You can use a PERC rule, pulmonary embolism rule out criteria, to actually rule out that it is no risk of PE. And in that scenario, we don't have to do anything, and we can safely say that this patient has low well score, they are PERC rule negative. We are confident objectively that this patient doesn't need any further workup, and we don't have to think about PE. Having said that, there are other scores used all over the world. There's a revised Geneva score. The good thing about it that it is purely objective. There's no physician gestalt included in that. In UK, there are also the NICE guidance and British Thoracic Society risk certification. Um, but what I have observed more or less is either in the UK, most of the time it's the Wells score that is used. Sometimes the NICE guidance used. And what I want you to take home is that it doesn't matter which scoring system you use, because more or less their effectiveness is the same. As long as you use any decision making rule, that is fine. Just use one system, whatever works in your hospital, that's fine. But as long as you're following a decision making tool to stratify these patients, that's fine. um, in most studies, Wells criteria was found to have a better performance than a revised Geneva score. But as I said, their performance is more or less the same in multiple studies. So once you have used the Wells criteria, how to make a low risk score, for example, a score of less than 2 on Wells criteria, what to do next? So you can use, as had, a PERC rule. Use the PERC rule. If all of them are negative, you are confident the patient has no risk factor and their chances of having a PE is less than 2%. So this is basically old data. This PERC study was done in 2008 in America by a group of emergency physicians, and they came up with this criteria to actually effectively rule out a PE in patients. And it was later validated by in studies in 2012. So it's quite almost 8-year old or 10-year old data that we're using, and they've been prospectively validated later on to show that yeah, they actually work. So if we say that this patient is Wells low score and PERC rule is 0, we are basically saying that their chances of having a P is less than 2%, which is still, I would not want to be that 2 in 100 person who has a PE, but still is a quite a strong objective evidence for you to say that you have effectively ruled out PE. And now we come about the D dimer, basically, which is always talk about PE, always think about D dimer, which is true. It is a very sensitive test for checking out pulmonary embolism. The problem is the sensitivity is very high, specificity is very low. So it can be falsely positive due to cancers, trauma, pregnancy, surgeries, liver disease. So it can be positive due to anything. So if you order a D-dimer, you should be having enough evidence. Your either your PERC rule should be your is not negative. It's scoring something on the PERC rule, or you have moderate risk on Wells criteria. Only then you should be going for a D-dimer. Initially, it was just a normal single cutoff, but now we use 8 adjusted cutoff, which basically means less than 50-year-old, you use a cutoff of 500. Uh, uh, if it is less than 500, it's negative. It's more than 500, it's positive. If the patient's age is more than 50 years old, then you multiply them by 10. So if age is 65-year-old, so their D-dimer cutoff for PE will be 650. If they're 80-year-old, their cutoff will be 800. So basically, that's how you use a D-dimer in the context of PE, because it can be falsely positive in a lot of patients without PE, and you just go down that rabbit hole, digging a hole for yourself and going for CTPAs, unnecessary investigations, unnecessary treatments. So just think about that. And this is basically the workup that I'm talking about. So I want you to, it's not the only flow chart that you can find. Obviously, you will be able to have your own departmental guideline, but this is something from my own trust that I'm showing. And it is based on more or less all the other guidelines that are used all over the UK. So if you calculate, look at the top, it looks very busy, but just let's break it down. If you calculate the well score, and you're having a score of 0 or to less than 2, you apply the PERC rule. If your PERC rule becomes negative, PE is excluded, essentially look up alternative diagnosis. If your PERC rule is not negative, if you have any of them positive, or your well score is between 2 and 4, then you go for a D dimer. And evidence suggests that you should also start treating them with anticoagulation even before you're waiting for a CT results or CTPA results, because they might be having low molecular, if their D dimer is positive, so you don't have to wait for a CTPA result. You can just start low molecular weight heparin if there are no contraindications. However, if their score is more than 4, then you can always start low molecular weight heparin, start treating them, assume them as their PV, and arrange diagnostic imaging as a CTPA or PE, VQ scan, whatever is available. And discharge wise, I'll come to that. When to discharge, what to do about that in a little while. So definitive diagnosis wise, we have the CT scan, ventilation perfusion scans, or pulmonary angiography. The CT scan is the most commonly used. The good thing is that it can show you the size of the clot, the location of the clot, any increase in the size of the right ventricle or RV strain, and any alternative diagnosis. The downside is you're using radiation, you're using money, it not might not be available everywhere. So, and it needs contrast. So all these things have to be considered as well. Ventilation perfusion scans. So as I said, its sensitivity and specificity around 90% the CTPA, and it will show you the clots as well as some indication about the strain due to the clot itself. And any patient above 50-year-old or significant comorbid conditions or abnormal chest radiograph, they are basically, because they cannot go for a VQ scan, they are contraindicated. So go for a CT pulmonary angiogram. The VQ scan is a less risky modality, but not easily available everywhere. It just checks the ventilation, the mismatch between ventilation perfusion and a pulmonary embolism. And if you have two or more areas of mismatch on a VQ scan, it's 80% chance that they have a PE. But you, as a prerequisite, you should have a good pulmonary ventilation function. Um, the risk, there is a small risk of cancers, especially if you're doing in a pregnant patient. So there's a risk of cancer, childhood cancers in the babies, but that small risk you have to balance it with the risk of increased risk of malignancy due to CT-PA. So you have to weigh the pros and cons while doing a CT versus VQ scan. Um, um, and pulmonary angiography is now, I think, more or less obsolete. It is helpful in a way that if you are able to do it in some centers, you have the facilities, it is more real time. You will be able to find out where the clot is, and if you have the facility, you can actually do the intra-arterial thrombolysis and dissolve the clot right there as well. You can place IVC filters and stuff like that. So this is something that used to be in practice a lot previously, but not too much anymore. Treatment wise, when we come to treatment, so the treatment more or less is anticoagulation most of the times. Our options are unfractionated heparin or low molecular weight heparin. Most commonly enoxaparin is used. Recently now we are also using direct factor 10 inhibitors such as dabigatran, fondaparinux, or newer oral anticoagulants or direct acting anticoagulants called the rivaroxaban, apixaban, and edoxaban. In certain situations, you might need thrombolysis or surgical thrombectomy as well, which is dependent upon the facilities that you have and where you're working. So low molecular weight is the favored treatment most of the times. Its dose is 1 milligram per kg twice daily. Unfractionated heparin is favored only if it's a massive or submassive PE, because you can give intravenously, it acts instantaneously, and you can start an infusion right away, and you can adjust the doses if it's renal failure patients or and they have extremes of weight as well. Once we initially anticoagulate them, then long-term treatment can be done on warfarin or dual anticoagulant treatments. Recently in UK, at least, I think all over the world, the recommendation is for the long-term treatment, dual anticoagulants, direct acting anticoagulants such as apixaban, rivaroxaban. These can be used, and they're shown to have as much effectiveness as the other anticoagulation, while having almost half the risk of a major bleed. So there are certain studies that showing they have a relative risk of 0.45, which is like they have almost half the risk of having a major bleed as compared to other anticoagulations. A duration of anticoagulation, it's better to start them within the 24 hours. The risk of having a major bleed is still very low. So you can start the treatment if you think the patient is high risk for having a PE. If it's an unprovoked PE, which basically means that you don't have any underlying cause, they could not find any underlying reason for it, it just happened without any reason, then the chances of getting a recurrent PE is 15%, and you should be giving them treatment indefinitely with anticoagulants. If it's provoked PE, so you have a reason, someone who had a long flight or who were immobilized due to long surgery or whatever underlying cause it is, then your chance of having a recurrence is 3%. You can stop the treatment after 3 months, and that's what the guidelines say. Okay, time for another quiz now, and let's see where we can go with this. Uh, so this is the second MCQ I wanted to share with you guys. So a 53-year-old female brought with severe respiratory distress and looks pale and sweaty. Her saturation is...
Sorry, Mohsin, we can't see the screen.
You cannot see. Oh, okay, sorry about that. I think I've not shared it correctly.
Yeah, that's fine now. Thank you.
It's fine now? Yeah, thank you. So a 53-year-old female is brought with severe respiratory distress and looks pale and sweaty. Her saturation is 82%, so I think it's a typo, on oxygen, and has a clear chest. And while you're examining her, trying to get an ECG and all, she suddenly goes into cardiac arrest. So how will you modify your cardiac arrest management? Thrombolize, yes. Yes, I think this is the right answer. Thrombolysis should be done because the patient's clinical picture goes with pulmonary embolism, and if you are able to, while doing the cardiac arrest, if you have the facility of having a bedside ultrasound, you can look into the heart, see there's a right ventricle dilation, large right ventricle. It indicates it's a massive PE. Thrombolize them. In that situation, your cardiac arrest should run another 30 to 40 minutes at least, so that the thrombolysis can work and you can give them a chance of uh, having an active, having it act and give them a chance to recover having a ROSC. Let them go. Let's go back to the presentation again. Okay. So this is the bedside ultrasound. I know many places in Pakistan would not have a bedside ultrasound, but it's very commonly used nowadays. And on the left side, if you can see, is the parasternal short axis view of a normal heart, and you can see that RV is there, the LV is there, and LV is most of the time is larger than the RV. As you can see in the lower left part, it's the left ventricle is larger than the right ventricle. But in case of a massive PE, on the right side of the pictures, both upper and lower, you can see the right ventricle is quite dilated, is always pushing the left ventricle into a small size. So there are certain signs we look at in the emergency department while doing these bedside echo, and we can say that, yeah, it's a massive PE and we can treat it right away. And this is when you can thrombolize the patients. So if a patient having massive PE, a cardiac arrest, or a severe submassive PE with worsening hypoxia, you can start them on and thrombolize them, and they can actually be life-saving. So you have to think about the risks and benefits of this thing before you go ahead. There are certain criteria to see which are the severe PEs, or which I have mentioned here. And if they fulfill the criteria, then you can go for anticoagulate thrombolysis. Surgical embolectomy is very rarely done, but it's one of the options. You can just directly remove the clot from the body. Disposition follow-up wise, most of the patients will be admitted. If your if you calculate a simplified pulmonary embolism severity index and their score is 0, then they can be discharged with a respiratory clinic or medical outpatient follow-up. But that, I don't know, in Pakistan we have that kind of strict follow-up or healthcare facilities. So I would say in Pakistan most of these patients will be admitted regardless. But in UK, certain patients can be treated at outpatient basis as well initially. And severe PE, of course, will need an ICU care. So this is the simplified pulmonary embolism severity index score that you can use to calculate at the time of diagnosis of a PE, and that can help us decide when to admit or discharge the patient. Um, Another question now. This is my last question, I think. Let's go back. Okay. I don't know if you guys can see it now or not.
No.
Okay, just give me 1 second. Let me share it. Can you see it now?
Yes.
Yes, we can.
Yes. So you're seeing a 32-year-old lady. She's 8 months pregnant, presents with acute shortness of breath, sharp pain in the left side of the chest, no cough or flu. Her GC is normal. You suspect PE. What will be your first investigation? First investigation. That's the tricky part. Can it be a VQ scan? It can be a CTPA. Can it be a D dimer? Could be a chest X-ray, or it can be a compression ultrasound of the lower limbs. Yes. So your first investigation would be ECG and chest X-ray, basically. So yeah, chest X-ray, I would go say the guideline says you should have a ECG done, and if the ECG is not showing something clear cut, go for a chest X-ray to look for any alternative diagnosis. If the chest X-ray is normal, then your next step should be to go for Doppler ultrasound of the lower limbs, and according to that, I'll just come to that in a second. What to do next when you have normal or abnormal Doppler ultrasound finding. So in pregnant women, as I said, perform ECG, do a chest X-ray to rule out alternative cause. If nothing there, do a Doppler ultrasound. If the Doppler ultrasound is positive in the lower limbs, treat it as a PE, start anticoagulation. If there is no DVT on the ultrasound, then you have to think about VQ scan or CTPA. As I said earlier, VQ scanning carries a slightly higher risk of childhood cancer in the offspring, but you have to just risk and benefits. Basically, you have to think about that it carries a definite lower risk of maternal breast cancer. So just you have to just look into the risk and benefits as well as the cost and availability of whichever investigation is available to you. But instead of doing a D dimer for every pregnant patient, which will be positive most likely, you should think about this pathway. And there's an algorithm talking about pathways that is used. It's called the pregnancy adapted years algorithm. So if you think about the left upper part of the pathway, if you have a suspected PE patient of pregnancy, you can order a D dimer, but at the same time use the three criteria of years criteria. Do they have clinical signs of DVT? Do they have hemoptysis? Or do they have a PE? Do you think the PE is the most likely diagnosis? And then according to do their DVT exam, do they have any signs of DVT and their ultrasound is positive, just start the anticoagulation. If the ultrasound is negative, then you adjust your D dimer cutoffs according to your years criteria. If there's no years criteria, your cutoff will be 1000 for D dimer. And if your years criteria is 1 to 3, you have a D dimer criteria, a cutoff of 500. And according to that, you can rule out or rule out PE or go for further workup. And according to this study, the years group that did this study, they were able to avoid about 30 to 60% of CTPAs in their study. So it's a very big number that you can avoid in a patients like that. Treatment in PE, you cannot give warfarin because of the teratogenicity, obviously. So you can give unfractionated heparin or low molecular weight heparin because they don't cross placenta and they can be safely given. Finally, another scenario I want to discuss with you guys. So a 70-year-old female with history of diabetes, hypertension, and recent diagnosis of PE. Now she's coming back again with worsening shortness of breath, and since it's similar to what she had when she was having a clot in her lungs. She is stable hemodynamically with mild tachypnea of 22, but normal stats and blood pressure. And she is already on warfarin and compliant with her medications. What will you do next? If someone is already in having PE, already on anticoagulation, what do we do? And they're already on the treatment. So do we just let them on the treatment, on the same treatment? Do we work them up again? Do we do a repeat D-dimer? That's a question that we encounter very frequently. So this is a workup that this is a pathway that I can tell you. So if you have to think about, first of all, if you do a recurrent workup, you do a CTPA, and you find out that there is a new clot compared to their previous imaging, then you can think about why this is happening. Is it due to they were not compliant to their medications? If they are not compliant, as you can see on the left half of left lower part of the flow chart, and then you can just reinitiate their first line anticoagulation and optimize their compliance. Is it due to the sub therapy? So maybe they were on warfarin, but their INR was not therapeutic. So you can just reinitiate the first line anticoagulant, the enoxaparin, for example, and then you can later on turn to warfarin on a therapeutic dose. If it's a therapeutic failure, for example, they were on normal dose of dual anticoagulants or direct acting anticoagulants or warfarins, and despite that they were able to get a recurrent PE, then you can think about should we give them start them a full dose low molecular weight heparin at least for 4 weeks, and then later on change it. If they are already on a full dose of low molecular weight heparin, then you can give them a escalated dose of low molecular weight heparin at 120 to 125% of their body requirement. And if it is having despite that and they're having it, then you can to think about if they're due to underlying cause. So for example, they have a malignancy that has not been treated yet, or they are potent post-thrombotic state, that is antiphospholipid antibody syndrome, or you can treat them with warfarin, or if they have other tendencies such as paroxysmal nocturnal hematuria or myeloproliferative neoplasm, you have to treat those underlying causes with the anticoagulation as well. With this now area of COVID-19, I just want a quick slide about COVID-19. We have a lot of patients with having clots. So now recent NICE guidelines suggest that we should be assessing them for bleeding risk. You should start them on, if you think that they're even if they're COVID-19 positive and they're coming inside the hospital, they should be started on low molecular weight heparin prophylaxis unless contraindicated. You can use fondaparinux unfractionated if there's any contraindications, and they should be on VTE prophylaxis for as long as they are in the hospital, or 7 days, whichever is longer. So this is the quick overview of PE. I hope I have not bored you guys to death. The take-home message I want you to take is the PE is more common than we think. So always consider it in an unexplained acute dyspneic patients. Having said that, the worst thing we can do is to do a D-dimer for every patient, and which will be positive in a lot, because it's non-specific. It will be positive for almost every patient. You will end up doing a lot of CTPAs, which we don't want to. So always have a workup plan, have your clinical decision-making rules to re-stratify these patients and see which patient needs the D-dimer and which patient needs further CTPAs or VQ scans. And you always you have to think about what are your treatment options, and if the patient needs any urgent treatment, or is it just anticoagulation should be enough. I'm at the end of my presentation now. Thank you so much for your time, and I'm open to any questions now.
Thank you so much, Mohsin, for such an excellent session and such useful practical tips. Do we have any questions from any of the participants?
Yes. Dr. Mohsin,
Yes.
thank you so much for the nice presentation.
Thank you.
I'm Dr. Hadi from Saidu Group of Teaching Hospital, Sawat.
Hi.
Recently, we have maintained our registry in our department regarding the PE patients.
Mhm.
And we have a very good experience with bedside echocardiography.
Okay.
And that has avoided so many CTPAs because the cost in this part of the world doesn't matter. So any patient who presented with the submassive and massive pulmonary embolism features, the bedside echocardiography have a very important role to play. And we have done so many treated the patient of PE, and they have responded very well. Even the follow-up echocardiographies at the bedside has improved the RV size and the strain as well. So I will again emphasize in those parts of the world where CTPA is not frequently available, the bedside echocardiography plays a very important role.
Exactly.
And in this continuity, I would like to ask one thing. Two of our patients who later on came out to be having mesothelioma, and the one patient came out to be having multiple myeloma. So my message for the trainees will be that all those patients who have the age group of more than 50 years age and they presented with the PE, So they should be worked out for further any underlying malignancy as well.
Exactly, exactly. So first of all, nice to see you, Dr. Hadi. I don't know if you remember me or not, but I was your house officer at KTH at one time.
That almost it.
And so it's nice to see you. I totally agree. Bedside ultrasound is now very, very commonly used, especially in the emergency department nowadays all over the world. And I hope now in Pakistan, although it's a very fancy and expensive equipment, but I hope our hospitals can invest in that, and it can help you in not just in PE, in a lot of other situations as well. So it can definitely, it's a very handy tool. You can always just patient comes in, you put the probe on their chest, on their heart, on their lungs, and on their tummy, and it can give you a lot of real-time information. And especially if it can tell us if the patient is sick enough that their life is in danger. If you find put a probe in, you don't see any massively enlarged right ventricle, at least you have some reassurance that yeah, at least it's not very bad situation. Is still we can buy some time and do some further workup. So it definitely helps. As per your underlying cause, exactly, the patient, once they get admitted to the hospital, they should obviously should be looked for any underlying cause. Why did they have a PE? So for example, if someone had a long flight from Australia or America, that makes sense because they were immobile for a long time, or someone had a plaster cast in the lower limb and they were just sitting there, or they were pregnant recently, postpartum. So yes, they that obviously there. But if you cannot have any obvious reason for it, then you should obviously, they are worked up and looked for underlying cause. It can be malignancy, or people can have inherited or acquired hypercoagulable states, so that have to be treated as well. Having said that, in terms of underlying cause, if someone's having a central line, so when you're treating them for PE, you have to consider if the central line can be removed or not, because that is the most likely source for it as well. Any other questions from any other areas or any other participants? So I just wanted to know what's the situation in Pakistan? Do we normally, is it a common diagnosis in our practice in pulmonary embolism? How frequently do we see that? If anyone can answer that.
Dr. Mohsin, in our north part of Pakistan, especially in our cardiology department, we are really receiving very good number of PE patients, almost from 2 to 3 or 2 to 4 patients on weekly basis. Okay. Even at this moment, we have a patient who had a massive pulmonary embolism, bilateral pulmonary trunks. They are full of pulmonary trunks are full of clots, and he was having a drop in his blood pressure as well. And we thrombolized that patient with a streptokinase. And the streptokinase with the thrombolysis and the massive who are hemodynamically unstable, they are really giving very good results.
Today we discharged that patient. His BP was 130 by 90, good, and saturation was 95 at room air.
So our PG just updated me that yesterday we thrombolized that patient with the streptokinase. At that time, his systolic blood pressure was 90. He was very short of breath. And now today, yesterday he was thrombolized, and today he was discharged home with the systolic blood pressure of 130. So
very nice, very nice. This is excellent practice, Dr. Hadi. Very nice practice. And just wanted to know, do we admit every patient with PE, or because in UK, as I said, there are certain group of people who are having pulmonary embolism severity index. If it is 0, we can actually discharge them on oral anticoagulants or even enoxaparin, and they are followed up in the acute ambulatory care clinics or respiratory clinics. Is that a possibility in Pakistan, or is it just too much we are asking at the moment?
Regarding our setup, we usually admit every patient who has suspected pulmonary embolism. The reason is on single visit, this is, I think, impossible to label someone that you have having PE. So you have to admit the patient for certain workup like the D-dimers, the bedside echo, maybe the patient may need CTPA. We have treated PE, confirmed PE patient, we have the normal saturation even. So you have to keep your threshold very low for the diagnosis of PE. So normally, I think in nearly 100% patient, we admit patient for the PE workup. And the good thing is all those patients having submassive or low massive pulmonary embolism, the patient who we treated with rivaroxaban, they have given very excellent results. So our experience with rivaroxaban in this part of the world is very good.
Very good, very good, excellent. That's very nice to know. Okay, I think we are. Do we have time for more questions, Nizam or Zabia?
We can, in case if anyone has a question.
Yeah, just let me know if they have any other questions.
Hi, Mohsin. I have a question. It's about the protein C, S, antithrombin, and factor V Leiden.
Yeah.
I was actually speaking to one of the hematologists, and he was saying that first of all, these tests take forever to come back, and they will definitely not change the management. The main thing that we look for is whether the DVT or PE is provoked or unprovoked. Do you have any experience with that? Or because we have hematologists here, so I have just wanted to bring that discussion as well.
Thank you for your question.
Thanks,
I don't, sorry, I didn't get your name.
And this is Siddiq, Siddiq Akbar.
Siddiq Akbar. Nice to see you, brother. From the States, is it? Where are you nowadays? Anyways, regarding your question, you're right. The diagnosis of these fancy underlying causes is not acutely. It doesn't really matter acutely what's causing the pulmonary embolism right now when you're there presenting to your emergency department or your clinics. Because regardless of that, what matters to you, is it a massive PE or submassive PE, or it's just a subacute PE, whatever it is, because treatment depends on that. Having said that, in terms of their recurrence of PE, that they might have a recurrent PE, if you stop their anticoagulation, you have to work them up to find out was it a provoked or unprovoked PE. So in our practice, when we get a patient having a PE and they get admitted, if they don't have any obvious cause for it, then the medicine doctors or hematology consultants are involved, and they look it up and try to find out exactly why they did have this PE. So as Dr. Hadi initially said, it can be simple, it can be malignancy, underlying malignancy that was not diagnosed earlier, or due to estrogens, or what was due to any hypercoagulable state for whatever congenital or acquired. So in terms of their long-term management, do we have to continue their anticoagulation more than 3 months or not? It definitely matters to find out. But I'll let Zabia talk on it in detail, because probably she's the right person to answer that question.
Thank you, Mohsin. So obviously in my practice, we see a lot of confusion about these investigations, particularly about inheritable thrombophilia. And Siddiq, if you are interested, I can send you some very useful guidelines about it. So basically the general consensus and the agreed guideline is that even in the event of an unprovoked PE or a DVT or venous thromboembolism, we would not randomly investigate everyone for the inheritable thrombophilias like antithrombin deficiency or protein C or protein S deficiency. So family history is particularly important in these particular scenarios. So you take a family history, and if there is a family history of quite a lot of provoked VTEs in the family members, then in those patients, you would consider investigating for inheritable thrombophilias. And the other thing is that if it is going to change the management of your patient, like if your patient is going to be on lifelong anticoagulation, irrespective of these investigations, then probably it doesn't worth running these investigations. The reason being that for all of these investigations, you would have to hold the anticoagulation for at least a week. And obviously, most of these patients would be at a very, very high risk of having a recurrent VTE. So if the plan is that we are going to anticoagulate them lifelong, then most of the time we do not run these investigations. But if there is a possibility that there is a familial thrombophilia and other family members need to be investigated, then yes, in those cases we would run them. But again, not randomly in every patient. Only if there's a very strong family history of recurrent unprovoked VTEs, then in those situations we do run these investigations. Hope it answers the question.
Yeah, thank you for explaining. Yeah.
Very nicely put, Zabia. It's, very nicely said.
All right. Do we have any other question from anyone else?
Thank you from our side, from SWAT. We have questions. No
Thank you so
questions.
much, particularly Saidu Teaching Hospital. And I must say that I'm really impressed by the standard of care that you guys are providing, because whenever we have a discussion about the services and the quality of work you are doing, consistently it has been very much up to the mark despite of the limited resources. So I must appreciate and I must say that very well done. And thank you so much for taking out time and joining us today. And thank you, Mohsin, for such an excellent presentation. It was very useful.
Thank you.
And hopefully we shall see you all next month with another presentation and another tutorial.
Sure. I want to thank everyone for your time. Thank you so much.
Thank you.
Thank you. Take care.
Thank you. Thanks a lot.